The broadcast is now starting. All attendees are in listen-only mode.
Good afternoon, and thank you for joining the RLS Foundation's webinar titled SIBO and the Gut Connection to RLS. My name is Zibby Crawford, and I'm Marketing Coordinator at the Foundation. Before we begin, please be aware that all attendees will remain on mute during this hour. We thank you for the questions submitted with your registration. Dr. Weinstock will answer as many questions as time allows at the conclusion of his presentation. After the webinar, you will receive an email with a link to the recording. The recording will also be made available in the member portal section of our website. If you are not a Foundation member and if you'd like to view this and other recorded webinars, we invite you to become a member today by going to www.rls.org. As always, individuals suspecting they may have RLS should consult a qualified healthcare provider. Information offered in this webinar is for informational purposes and should not be considered as a substitute for the advice of a healthcare provider. Our speaker today is Dr. Leonard Weinstock. Dr. Weinstock has a clinical teaching appointment as an associate professor of clinical medicine and surgery at the Washington University School of Medicine in St. Louis. Dr. Weinstock's lectures and research have been presented at national and international conferences on diseases of the esophagus, stomach, small intestine, and colon. He is actively researching the connection of the gut and small intestinal bacterial overgrowth, or SIBO, with several medical problems, including restless leg syndrome and chronic pelvic pain syndromes. Dr. Weinstock, we thank you for sharing your time and your expertise with us today. I now invite you to begin the presentation.
It's my pleasure. It's hard to talk about SIBO without talking about inflammation and how I treat inflammation. So that's just a cue that this is going to be a little bit more than just about a few bugs. So we'll review basic physiology, a lot of which has been presented in other lectures, the role of small intestinal bacterial overgrowth, the antibiotic studies that I've done, and how does inflammation fit in, and what's going on with endorphins, and what have I found in rifaximin plus low-dose naltrexone, a treatment that triggers the body to make endorphins. So we're going to go over all of this in a short 45 minutes. Now, in the top four bullets, these are things that have been discussed in other seminars, or you may have read these theories of pathophysiology for restless leg syndrome in the readings that you do. I don't think you've seen too much on SIBO, inflammation, immunity, and endorphin deficiency, but these have become recently publicized in the journals. I'm going to also say that these three new things, relatively new things, relate to central nervous system. Accepted that if the brain is low in iron, it can cause restless leg syndrome or worsen it, and it's found both in primary and secondary restless leg syndrome conditions. It decreases the D2 receptor functions in the brain, and in an autopsy study done by Dr. Clardy, they found that there was increase in hepcidin. Hepcidin is a hormone produced by the liver which regulates iron transfer and absorption. So the higher the hepcidin produced by the liver, the lower the iron. So we'll keep that in mind for the next few slides. There is a circadian rhythm to think about. And again, the amount of iron that can fluctuate into the brain could be one of the clues for why you get it at night rather than during the day. Hepcidin, it's a regulator of how much iron can be absorbed from the duodenum, and also how much goes in and out of macrophages and it's affected by inflammation. So next to the area where it says the liver, and it looks like liver, it has the LPS, lipopolysaccharides, and IL-6, that's interleukin-6. Those are inflammatory chemicals. Lipopolysaccharides are the outer coating of the gram-negative rod, which is a bacteria that lives in the gut, and it's shed into the bloodstream in the setting of SIBO. IL-6, interleukin-6, is a very potent inflammatory chemical, which is secreted and activated by T cells, which goes up in the setting of SIBO. And we'll go into that in a little bit more. But when this is going on and when these inflammatory chemicals hit the circulation and go to the liver, you get more hepcidin and less absorption from the duodenum and less transportation. And then in a nifty mouse study, they found that when there was inflammation by giving the mouse lipopolysaccharides, the covering of the brain started producing hepcidin. So this was even outside of the liver that this occurred. So that's pretty interesting. So let's think about what is our normal gut doing and how things are regulated so we don't get an imbalance of the bacteria. We all have bacteria in our gut. In fact, if you looked at the number of bacteria, it would be 10 to 1. So there's 10 times the bacteria sitting in our gut than there are cells in the entire body. Think about that. Now, 50% of the stool weight is bacteria. And but just living bacteria, we're talking about 10 times the amount of our skin, our gut, heart, all put together. And they all serve an important role in homeostasis and in absorption and protection against invaders, et cetera, et cetera. Now, you have very little bacteria in the stomach. You see where it says on the upper right, 0 to 1,000. Well, that's a 0 to 1,000 colonies of oral bacteria. And however, if your acid is produced by your stomach, if you swallow other bacteria, the acid will kill it. That's a normal protective factor. If you absorb all your nutrients, then you don't feed any bacteria in the small intestine. So the pancreas and the small bowel lining, if they're healthy, you absorb all the nutrients there and you don't feed the duodenum and jejunum bacteria. Motility is probably one of the most important things going on that keeps bacterial overgrowth from occurring. The motility is a motion, basically peristalsis, that occurs. There's a migrating motor complex. This is a peristaltic wave that occurs every 90 minutes while we're sleeping. And that propels any junk food, nutrients, and keep the bacterial counts very low in the mid-small bowel. Immunity has a role to play as well. We naturally have some higher amounts of bacteria in the distal ileum. So on the left side of the slide, you'll see that the counts have gone up, and coliforms means that these are bacteria that often generally live in the colon primarily, as opposed to oral bacteria. And the ileocecal valve, the ICV, this is a structural sphincter that when it's closed prevents regurgitation of stool and bacteria into the small intestine. So that's the basic gut and the bacteria and the most important structural and functional things that keep us free of bacteria. Small intestinal bacterial overgrowth, SIBO, is excessive bacteria, and there are certain definitions in terms of quantity, but let's just talk about what it really means. We've talked about the fact that it's prevented naturally by normal digestion and neuromuscular function. When you look at it, there are over 40 different causes for this condition. And just like any syndrome, you can have the same set of symptoms, but multiple causes. It's most often diagnosed by the lactulose breath test because sampling the small intestine with tubes and scopes are invasive, and culture methods are a little difficult for labs to do appropriately, especially since many of the bacteria are anaerobic as opposed to the typical aerobe bacteria that we find in probiotics that are on our pharmacy shelves. So what does it do to you? Well, if you have too many bacteria, those bacteria ferment gas and they cause bloating, gas, bad gas, usually in the form of passing gas, but also trapped gas. And in fact, 90% of the gas we make in the small intestine stays in the small intestine. That's why people bloat out. They can say they look pregnant or less so. And then it gets absorbed into the bloodstream through the lining of the intestine. And when it does, it comes to the blood, which goes to the lungs, which comes out your mouth. And some people actually have problems with bad breath, or it just takes a long time to get out of the intestine, so people stay bloated. And of course, one can have altered bowel movements, diarrhea, constipation, especially if there's methane gas, and malabsorption when the condition is severe, like conditions like scleroderma. And it has systemic manifestations. I mentioned some of them, the inflammatory cytokines or chemicals that are toxic, antibody formation, and more inflammatory cells, including the mast cell, M-A-S-T, and which I think is a very important cell. And maybe I'll be invited back to talk about that. Here are the basic causes for SIBO, which are basically the opposite of what I showed you, which were helpful. And if we have time, we can go over some of this later. The things that I'll touch on just a little bit would be anatomical changes, where let's say you've got a gastric bypass and there might be a sewer area where some of the small bowel doesn't empty well because it's not in the right place, or you've lost your acid, which is achlorhydria, which occurs in a bypass, or getting older. So the elderly who have restless leg syndrome may have that because they don't have acid production in their stomach, or people with severe reflux are taking proton pump inhibitors, the PPIs, and they reduce their acid well enough that they get bacterial overgrowth, and that's the achlorhydria. And then there are a variety of neuromuscular conditions. I'm going to just expand on one at this point. There is a condition called post-infectious irritable bowel syndrome. That's where you've never had illness before. You go to your friendly restaurant or to, then you get a series of events that result in an autoimmune antibody, and that antibody attacks the cells that are responsible for that migrating motor complex, the one that is the sweeper wave that cleans out the small bowel. And that is probably, at least what we can say, the most common cause of irritable bowel syndrome with diarrhea, and about 60% of people have these antibodies with IBS-D, and some of these people are the people who go on to get restless leg syndrome. So this is a little bit heavy, science heavy, but it's a repeat of what I've said before. It's a vicious cycle. At times, the TNF alpha increases gut permeability, which allows more bacteria to get in, shed their skin, so to speak, increasing hepcidin. Then that IL-6 damages the lining of the gut, and then the gut becomes more inflamed, there's more leaky gut, so to speak, and that creates more inflammation and more hepcidin production, and therefore less iron in the brain. So how did I get started with this idea? Just talked about post-infectious irritable bowel syndrome. I went to a conference where they were talking about rifaximin. Xifaxin's a trade name. There's no generic available in this country. Anyway, my cousin Steve, he had post-infectious irritable bowel syndrome and restless leg syndrome that occurred around the same time after a bout of food poisoning. I thought, well, maybe they're connected. And so I gave him the antibiotic, and he had dramatic improvement in his restless leg syndrome. But unfortunately, his periodic motor limb disorder did not improve. And that's a picture that I drew of Steve, and he's better to a degree. Another patient around that time had many things happening at once. All started with a bad infection, which led to severe post-infectious irritable bowel. She developed fibromyalgia a year later. And then 9 years after her original onset of irritable bowel, she had restless leg syndrome. 3 years after that, interstitial cystitis. She came to see me. She had an abnormal lactulose breath test. Treating her with this rifaximin, she had dramatic improvement, and she's been doing very well. Initially with preventative therapy to try to get the small bowel to activate using low-dose erythromycin, and later low-dose naltrexone, LDN. So I looked at our patients who were treated with an open label study. And again, open label studies are only so good because there's always the issue of placebo response. It was a small group with patients with irritable bowel, SIBO, and restless leg syndrome. In the middle section, you see how they were treated. I use a higher dose of rifaximin now, a pro-motility drug, and then after the treatment, then I give things that help restore the gut lining, probiotics, and zinc. And in this group, 77% had a great 80% or more improvement in their restless leg syndrome. And the follow-up was a mean of 60 days. 6 of 13 patients had 100% relief. And this does not occur in restless leg syndrome. And I think you know that. Another open label study, idiopathic restless leg syndrome, just all comers, 21 patients. They were treated with rifaximin, and then they were given pulses of rifaximin. 71% had a positive breath test. About 3/4 were global responders, and they said they got better. And this RLS scale, the severity of international restless leg syndrome scale, had a 66% improvement in these patients. Of 5 who didn't respond, 2 got better when I treated with 2 antibiotics. Here, I don't know if you can see my arrow, but a pretty high restless leg score. And then they kept going down in time for these 14 patients. And they got a steady dose and then pulse dosing along the next 20 days. Finally, I did a double-blind placebo-controlled study, very much the same group of patients, but they had to have an abnormal breath test, and they had to have a pretty significant restless leg syndrome, and they couldn't be low in iron. They were randomized, and they were given the higher dose of rifaximin or placebo for only 10 days. And again, now I use it for 14 days. And the placebo group in yellow, nothing much happened, as you'd expect. But during the course of the rifaximin, the RLS score dropped from a mean of 25 down to 21, which was clinically significant in the patient group. And then as the antibiotic wore off, the effect also wore off. Now, in this double-blind placebo-controlled study, of the breath test patients, 33% had no GI symptoms. So that's pretty important. You could say, well, what if I don't have bloating, gas, diarrhea, but I have restless leg syndrome? Could I have bacterial overgrowth? And the answer is yes, you could. So now I've told you about some of these, the SIBO, the role of inflammation and immunity, possibly in CNS iron deficiency. And we're going to talk a bit about endorphin deficiency too. But before I go on to that, let me say that the prevalence of SIBO in primary restless leg syndrome is something that Dr. Walters and I looked at. And so we had 69% of restless leg syndrome patients had SIBO, an abnormal breath test. And that was clinically significant. We took a group of totally healthy controls, and they had a positive breath test in 11%. So about 1 out of 1 out of 30 had a positive breath test. And that is in contrast to nearly 70% of patients with primary restless leg syndrome. These primary restless leg syndrome didn't have irritable bowel, they didn't have liver disease, they didn't have celiac disease. So this was published and is, impressive data to start thinking about the importance of SIBO, the gut, and your legs. Now, one thing that we did was in 2012, looked at every single condition that's ever been reported with restless leg syndrome. So these are secondary restless leg syndrome conditions. And we found of 40 conditions, there were other separate reports of iron deficiency in 25, SIBO in 15, and yet, of course, in many of these conditions, the SIBO test was never administered. And inflammatory and immunological reports are common. And so these are the groupings. And what I'm going to do as a gastroenterologist is just talk for peptic ulcer disease, which is rarely done anymore, and chronic liver disease were reported. And then Dr. Walters and I looked at irritable bowel syndrome, celiac disease, and Crohn's disease. And the Crohn's disease was a multi-center study that I organized with 4 different institutions. And when you looked at these things, iron deficiency, SIBO, and inflammation was very common throughout all of these medical GI conditions. For celiac disease is shown here, and this was published in 2009, around the first time I met Dr. Walters, who's studying restless leg syndrome since 1975. So I had 85 patients, 35% had a prior and or current incidence of restless leg syndrome. The prevalence, namely they had restless leg syndrome when they saw me, was 25% versus 9% of spouse controls. And 21%, interestingly, started before GI symptoms. So some of you asked, well, what about gluten? Could that relate to restless leg syndrome? And the answer is absolutely. So many patients have non-GI symptoms before the GI symptoms start in celiac disease. Iron deficiency was common, and 50% of the patients improved with gluten-free diet, GFD. Crohn's disease was very similar. The incidence was 43%. When they were seen by the doctor, 30% of Crohn's disease patients complained of restless leg syndrome. versus 8% of their spouses. Most of it started after their Crohn's disease started. And then, very interestingly, thinking about the inflammatory issues, 45% stated that their restless leg syndrome was associated with the GI activity. And I have patients where they get their restless leg syndrome, they get their diarrhea, I get more aggressive with the treatment for the Crohn's, and both the Crohn's and the RLS get better. Irritable bowel syndrome was reported in an abstract by a New York gastroenterologist, Dr. Basu. He found that 29% of his IBS patients, pretty good sized group, 90, were experiencing restless leg syndrome, and the risk was higher with IBS diarrhea as opposed to mixed diarrhea, constipation, or constipation alone. Restless leg syndrome and irritable bowel syndrome. So this comes from our work and then contrasted to epidemiologists. So in the study of 59 restless leg syndrome, close to 40% had irritable bowel syndrome. And that is in contrast to roughly 8% of the general population. It varies between 8 and 15% have IBS. But in our restless leg syndrome group, 40% or so had irritable bowel syndrome. This is complex, but let me just highlight just a couple of things that there are 3 good studies that look at inflammation and restless leg syndrome. And some of this is just too heavy to get into, but I just want to bring it out. But also periodic motor limb disorder is also associated with inflammation. And it's possible, if we can find the underlying cause for inflammation and treat it, that the jerking, kicking movements while sleeping could get better. So I said that endorphin deficiency was an important role to think about in cause for restless leg syndrome. And this is studies by Dr. Walters. He did an autopsy study using bank cadaver tissue that they had at Mayo Clinic and made available for researchers in RLS. And he looked at endorphins. And I think part of his initiation was and thought process was that a lot of people with severe RLS get better with narcotics, so opioids. So the question is, did they not have enough opioids in their brain, perhaps? And so he found that there was a significant reduction in endorphin levels, which are basically our body's own opioids or narcotics, if you will. These are his studies showing control, where you see a lot of these orange dots versus less in the restless leg syndrome brain. And another enkephalin, which is a type of endorphin, where there's more on control side than patients with restless leg syndrome. And then 2 clinical studies helped back up the idea that this made sense or was important. A cell culture that they applied, they basically made it iron deficient, and they put the brain cells in there, and they added the endorphin and enkephalin to some of them, and basically protected those dopamine cells, the DA cells, from cell death because of iron deficiency. And so basically we're saying you could abstract to humans and say, well, if the brain's low in iron, maybe some of these dopamine cells are either performing poorly or actually dying off, and giving what you're missing, namely endorphins, could help you. And there's another study that was done with using a PET scan, And this is a little difficult to interpret, but basically less binding of the endorphins, therefore less endorphins, the worse the severity of the RLS. Now this brings me up to case 3 before I get into naltrexone. So this woman had 3 years of restless leg syndrome. Now what was interesting about her is that it was pain, and every time she went to bed she said, I'm going through my nightly torture, which is actually, if you go back to 1675, what was the original description of RLS, namely the nightly torture. She had to move around in bed, didn't have to get up and walk. She had a problem with constipation. She also complained that friends, she thought she had bad, or acted like she had bad breath. And she got a breath test, and in 2006, she was making a lot of methane. And she was treated with rifaximin and initially a drug that was taken off the market to gas rods, but actually is back in the market, called Zelnorm. And we utilized that quite a bit for a while, but now it's back for other reasons, namely constipation. Well, she actually had to start a cholesterol medicine. So it was felt that the erythromycin could interact with the statin, and in view of anti-inflammatory properties of naltrexone, I decided to treat her with LDN. And that was in 2009. And in the course of 10 years, she has remained pretty much free of restless leg syndrome. She's had to retreat with antibiotics 3 times during these 10 years. And she told me this morning, while we were having our coffee, she is my wife, by the way, that for the last 2 nights, she's been having the pain again and the urge to move. So she's going to get a breath test and do it tomorrow morning, and then she will be retreated. So this is my wife, and if it's possible to put somebody's restless leg syndrome in remission, well, I've seen it firsthand. So LDN, it works in a lot of ways, and people have used it for so many conditions. In fact, there's a website, ldnresearchtrust.org, and they list 177 conditions. I use it all the time for patients with Crohn's disease, various skin lesions like psoriasis, dermatitis, ulcerative colitis, sarcoidosis, a number of different things. And if you want to see publications, you can easily look at them on ldnscience.org. And all my papers are there, but many others. And there are now over 100 studies in humans. Since 1984. And it was approved initially at high doses to prevent alcohol abuse and later narcotic abuse. And on the radio today, decreasing the need or withdrawal from meth. But what it does is, when it's used at high doses, it blocks the opioid receptors, which are the pleasure zones. In low doses, it basically tricks the body into making more endorphins, and endorphins reduce inflammation. They also block pain, and as you know, with restless leg syndrome, it's very painful in many patients, and it blocks receptors on white blood cells that sit on top of the sensory nerves. And that's one way that people get better from pain, from neuropathy, for instance, and I have a number of patients who have neuropathy. And as you know, a certain percentage of patients with RLS have neuropathy, so that's a potential role. So reduces inflammation. There's studies on patients with fibromyalgia that was a dramatic improvement in 15 different cytokines by the administration of LDN. It may increase motility and the migrating motor complex, as shown in a couple of studies. So I looked at patients who were treated with rifaximin and then given LDN, basically what my wife went through. I had 52 patients. Ultimately, 40 patients were looked at because they had more than one office visit after the treatment. So I could say they were compliant, they came back, I could see what they did. And here's in the middle, the protocol that I used. Most everybody had chronic GI symptoms, and of course, pretty much anybody who walks into my office are going to have GI problems. But nonetheless, most of them had a positive breath test, and most were women, which is fairly common. And in these 40 patients, 21 had a marked response. They were treated with Xifaxan and then they were given LDN. 5 had a moderate response. And so if you looked combined marked and moderate responders, 65% were responders. And then of course, you know, nothing works 100%. And I had a slide in here in terms of showing what was available for improvement after gabapentin and the dopamine agents, and you're looking at about a 20% improvement over placebo. So the treatment available for RLS is not great. So I looked at how much LDN was the best dose, because it varies between 2.5 and 4.5. Now, high dose naltrexone, which you're giving under the FDA indications that I talked about earlier, is 50 to 100. So it seemed like 78% were in the marked to moderate response if they were in the 2.5 milligram versus the higher dose. And I use the higher dose all the time for mast cell activation syndrome and for Crohn's disease, ulcerative colitis, sarcoidosis, etc., really the bad inflammatory conditions. But this 2.5 milligram dose seemed to hit the sweet spot. What if the breath test was normal? Then, you know, first of all, you can have false negatives, you can have false positives, but in this group, I decided, look, their breath test is normal. I'm not going to treat them. I'm only going to treat them with LDN. And there were only 7 patients, but 57% had the marked moderate response and 3 were unchanged. So we gathered this together in the LDN book. It's available. The editor and another LDN book is coming out, but we wrote a chapter in it and talked about the responders and how some of them were going up to 7 years of treatment. Side effects, SE, side effects led to cessation in that first group that I showed in 40 to 15%. And that's common. I would say in the Crohn's disease studies, 15% is the dropout rate because you're getting an endorphin rush, and some people can't tolerate the dreams, vivid dreams, the insomnia, or feeling jittery. There are other symptoms that can occur as well, but roughly 15% cannot tolerate the drug. I think it's better tolerated by starting at a very, very low dose and working up gradually. And there's probably less symptoms at 2.5 than 4.5. And unfortunately, 3 of the 6 patients who had side effects were in the responder group, and some had to drop out. I think 1 of the 3 kept going. Sorry, three of the 6 kept going, but 3 had to stop. So that's unfortunate. But again, they could have been in the 4.5 milligram dose group. So I try to start and go to 2.5 in my RLS patients with naltrexone. So I did a bigger study just by reviewing my charts, and 77 patients. They were both either with antibiotic therapy followed by LDN or just LDN alone. This gives the numbers you can look at later. Putting this together by again, looking at the rifaximin followed by LDN, moderate to marked, grouping them together since that's a reasonable goal. 40% improvement, 3 patients I had missing data on. And then they said, okay, what about, I asked them all, what about naltrexone after you were done with the antibiotic? How'd the LDN do, 2, 3, 4 months later? And there was a good response of 58%. 2 of these 26 patients stopped because of side effects, adverse events. If they were monotherapy, I had a bigger group now, 12 patients. It was 50% got better. And you know what? That's not bad. Of course, any scientist will tell you, well, this means nothing unless they do it in a double-blind, placebo-controlled manner. And I would agree that it needs more studies and more numbers of patients in the trials. So how about practical tips? Because some of these might be questions. Well, your GI doctor or primary care doctor, nurse practitioner, PA, they can order a SIBO breath test kit for you. And then the company does the breath testing. You do the test at home. It's an easy to do test. Cefaxin is hard to get unless there's IBS-D on your doctor's note, and it says that other things have been used, but they're actually herbal antibiotics, and in Canada there's a generic. LDN can be prescribed by anybody, but if your doctor says, well, I don't know about this drug, it's off-label. Yes, it's off-label. Many things we use are off-label, but there's actually ways to get LDN by telemedicine doctor, and the resources are from these 2 websites. What about the risks of LDN? Basically, because it suppresses the antibodies that are autoantibodies, you may need less thyroid hormone replacement in Hashimoto's. The glucose levels, if you've got type 1 insulin-dependent diabetes, the one that starts in childhood usually, you actually may need less insulin. You don't want to give it if you had an organ transplant. You do not want to give it if you're taking it because you're so this turned out pretty good. They wanted 45 minutes, and here we are. So SIBO is pretty common in idiopathic restless leg syndrome. GI symptoms overall are common, but you don't have to have GI symptoms to have SIBO in restless leg syndrome. In small case series, antibiotic therapy followed by LDN, or LDN by itself when there is no bacterial overgrowth, can reduce the severity of the restless leg syndrome. And then I also like to look at the patient as a whole when they've got SIBO and they've got an extra intestinal manifestation. So they've got chronic fatigue, restless leg syndrome, or fibromyalgia and or interstitial cystitis, that I want to treat that patient with the antibiotic, a low carb diet, um, low fermentation diet, a motility medication when appropriate. After the antibiotic therapy, give probiotics, zinc, a protein called glutamine, and LDN. And I also want to be aggressive with the iron, not only aggressive in terms of treatment, but as a gastroenterologist, find out why they're low in iron. Make sure they're not having celiac disease or Crohn's disease or colon cancer, et cetera, et cetera. And so this total package helps the patient who has SIBO and restless leg syndrome. Thank you for your attention.
All right, thank you. Here are some questions that came in with registration. Is there any connection with diverticulitis and RLS?
Not to my knowledge.
Okay.
Now there is let me say that there is a chronic diverticulitis, SUDS, it's called, SUDS, and maybe that can cause enough inflammation to exacerbate restless leg syndrome, but not necessarily as the primary cause.
All right. Can SIBO cause intestinal metaplasia? If so, can this state exacerbate RLS?
Intestinal metaplasia refers to either the esophagus with Barrett's or the stomach lining. Sometimes with gastric intestinal metaplasia, you have less pH, so less acid, and so that may give you more bacterial overgrowth.
Does the use of probiotics and large amounts of magnesium and potassium enter into this situation?
Well, giving somebody who's already has too many bacteria, more bacteria doesn't make sense to me. Those bacteria are not going to knock off the bad guys off of the small bowel lining where they're firmly attached. So I don't give probiotics until I've cleared the gut of the bad bacteria in excess quantity. Magnesium, there are a lot of people out there who have RLS where magnesium helps. But I don't think there's a direct explanation tying low magnesium and SIBO unless there's a lot of diarrhea, because then you'll become hypomagnesiemic.
During my RLS attacks, I have the strongest urge to eat protein of some sort. Could this be related to the gut connection?
Well, that's pretty wild. I think, patients who go on the high protein diets and low carbs and they have SIBO, they can get better. So how your body figured that one out, I don't know, but medically, it makes sense.
Can acupuncture be helpful for SIBO?
As far as fixing the gut I would say that sometimes the brain-gut connection can be altered by many things, which of course is a known thing that acupuncture can do. So I wouldn't exclude it, but I wouldn't say it's a permanent fix.
All right. How do different medicines commonly prescribed for RLS play a role in trying to manage the gut?
I don't think there's a great connection there. The dopaminergic agents, the gabapentin, I don't think it's a great thing. The problem with narcotics is that they slow down the gut and can make bacterial overgrowth worse. So I would say to any neurologist out there, before you put me on a narcotic for my restless leg syndrome? Can we try a low dose anti-narcotic?
All right. I think that when I'm constipated, I'm more likely to have bad RLS episodes. Is there any data about that?
There is data about methane and constipation, and there conceivably is an association where the methane could slow down the small bowel even more, and then that enhances the bacteria to attach and not be swept out. So that's a possibility.
All right. Is there a connection with candida in gut dysfunction and RLS?
So if you have RLS, there is a higher risk for having candida or SIFO, SIFO, and that was reported by a gastroenterologist. It took him 3 years to get the article published because most regular old MDs don't believe in candida. With respect to candida and RLS, I have not studied it. It's very hard to diagnose it with certainty, so I haven't looked into it. But the symptoms can be similar to SIBO.
Is there a specific diet to follow to change the condition of the small gut that would decrease RLS symptoms?
So I think, yeah, there's a book out actually. Dr. Walters and I wrote on the effect of diet, obesity, and sleep disorders. That's the name of the book. But the data is fairly thin. I think with respect to overall, it's been thought that carbohydrates and caffeine can make RLS worse. As far as SIBO, it's certainly a high carb diet. The FODMAPs, FODMAP, high diet is actually worse, is bad because you're feeding the bacteria with these fermentable sugars. And then so I think that the keto diet, the diets that limit carbs can certainly help out. The high fructose consumptions with the big gulp at 7-Eleven, that's probably going to make you worse.
Okay, what about people who have had Roux-en-Y gastric bypass for weight control?
Absolutely. You're creating a sewer. Some of these loops don't peristalse well. Just the nature of the surgery decreases the amount of acid that will get to the small intestine to kill off the bacteria. The bacteria can be colon bacteria because sometimes it goes rectum to mouth, if you will. And that's how many infectious diseases of the colon are passed, but basically poor sanitary hand cleansing, and then you eat something, and then your colon bacteria go into the intestine. So in the upper intestine, you're getting coliform bacteria, which are really bad. And then if you've got poor peristalsis and less acid with the Roux-en-Y or the gastric bypass, then you're there.
Yes, sorry.
Okay, just want to be sure.
Is there any relation to GERD, either with RLS or the meds given to treat it?
So that's one of the protective factors, is to have acid in your stomach to kill off the bacteria that we swallow. Every time we swallow our saliva, we're swallowing bacteria from our mouth. And yes, it's not as much as some people think it is, but proton pump inhibitors do increase SIBO, or the potential for SIBO, although if you're not infecting yourself with colon bacteria and it's just oral, it's probably not as risky because those aerobic bacteria are not as toxic as the anaerobic bacteria. So the bacteria that live in a situation where it's in contact with air, like your mouth, is different than the middle of your colon, which is without much exposure to air, obviously. And those anaerobic bacteria are more toxic in general if they get to a place where they're not supposed to be, such as the small intestine.
Is there any connection?
Sorry, I lost you there. Is there any connection?
Is there any connection to extreme lactose intolerance? Even the lactose in pill is too much.
Yes. Lactose is a nice dessert for bacteria, just like the lactose in your ice cream, resulting in acidic condition, cramps, and diarrhea and gas. There's some people who are sensitive to it, but they may actually have sucrose isomaltase deficiency. So anytime you're having, let's say, ice cream which has sugar in it, if you've had long-standing, lifelong irritable bowel syndrome, think about sucrase deficiency. SUCRASE. And that will cause other sugar malabsorption problems.
Okay, is there a way to test for SIBO, and what is the recommended treatment?
So there are 3 tests. The lactulose breath test, which some people say it overestimates the number of people diagnosed with SIBO because it can go through the small bowel rapidly sometimes and go hit the colon, and the numbers go artificially up. The glucose breath test, which minimizes the number of people who are diagnosed, but unfortunately minimizes the number of people who should have been diagnosed, because the glucose is absorbed in the first 3 feet of the 15 feet of small bowel. So what's going on in the middle of the small bowel is not detected by the glucose test. Basically, these tests, you're swallowing sugar of one type or the other, you're breathing into a bag, collecting that air in the bag with the test tube, analyzing it, and seeing whether the numbers go up early in the study to say, okay, I have or I don't have bacteria high up in the gut. And then finally, endoscopy can be done, catheters can be placed, liquid could be suctioned out and then cultured, but very few people do that or have a good lab to measure those anaerobic bacteria.
Okay. What probiotics do you recommend? Is liquid more effective than pill form?
I wouldn't say liquid's more effective. If somebody's trying to prevent, here are the things. If somebody has diarrhea, it's going to be something like Fluorostor or Culturel. If somebody has more bloating, constipation, it's going to be something like Align. If I just want an overall improvement, then I'm going to ask them to get a mix of Bifidobacter and Lactobacillus. If there's an issue with constipation, there's the Dannon product that's in their yogurt. It's a type of Lactobacillus. It's confusing because there's so many probiotics on the market, and it's hard to really know what is best because there are very few studies that have been done.
Okay, last question. What are your future plans for study between the SIBO and RLS connection?
I think more studies can be done. Dr. Walters and I are also embarking on the role of mast cell activation in restless leg syndrome. And we've published a paper, just was accepted for publication, that in this common syndrome that affects virtually any organ in the body, nearly 40% of our patients had restless leg syndrome. If you look at any secondary cause of restless leg syndrome, like irritable bowel, pregnancy, neurological illnesses, rheumatological, et cetera, you know, 40% is like an incredible number for restless leg syndrome to appear in a secondary syndrome. So I think that holds a lot of importance. In SIBO and restless and irritable bowel syndrome, the mast cell plays a role as well. So we might be able to tie it together there. And I'm just always looking and testing for SIBO and checking their iron and vitamin D when I've got an IBS patient who has RLS. And so I'm pretty aggressive about diagnosing. And then, you know, it's going to take grants and more money and more time to be able to do other studies. So right now I'm pretty much doing it on my own patients when they come in and trying to make people aware. And hopefully, you know, as far as making your own doctors aware, well, in 2015, Cefaxin was approved for irritable bowel syndrome with diarrhea. So there is no reason why your gastroenterologist or the nurse practitioner in their office who sees you for irritable bowel shouldn't be trying to see if you are, let's say, an antibiotic responsive IBS patient. And if you are, maybe you'll look at yourself and say, hey, did my RLS get better while I was treated for the IBSD? And if it did, you'll say to the nurse practitioner, hey, I've heard about this study and here are the articles that I pulled off of ldnscience.org. Could you give me a prescription for LDN? And go to your local compounding pharmacy. And ultimately the cost is 50 cents a day if you're not getting insurance to pay, which is a little tricky, but sometimes Walgreens will have a compounding pharmacy and sometimes they'll cover it. But at most, you know, for RLS, LDN is cheap. And if it works, if you're in that 57, 58% range where it helps, well, great. And it doesn't take, you know, traveling to St. Louis to get help for this. So I try to work with the mid-levels and show them the articles. They're just easier to talk to than doctors who have very fixed minds and require 10 double-blind studies before they believe anything.
All right. Well, thank you so much. This has been very helpful, and we appreciate everyone on the line. Our next webinar will be Monday, December 9th, where Dr. Brian Koo will be presenting on the topic of depression and RLS. Please go to rls.org to register. Thanks again, Dr. Weinstock, and thank you all for joining us.
You're welcome.